video is a continuation of my previous lecture in which we have discussed the pathophysiology of rheumatoid arthritis, how to diagnose rheumatoid arthritis, and the classification of drugs that are used in the management of rheumatoid arthritis. So today in this video we are going to discuss in details about the drugs that are used in the management of this disease. As we know that rheumatoid arthritis is a systemic autoimmune disease that results in chronic inflammation and production of autoantibodies. So there is abnormal immune response, there is excessive T cell activation, and the initiating interaction is between the antigen presenting cell and the T cell receptor. So this interaction results in abnormal or excessive T cell activation, and abnormal T cell activation results in chronic inflammation, activation of macrophages, monocytes releasing cytokines such as interleukin 1, 6 and tumor necrosis factor alpha. So cytokines such as interleukin 1, interleukin 6, tumor necrosis factor alpha results in a cascade of inflammatory responses, chronic inflammation, erosion of bone, cartilage damage, release of matrix metalloproteinases, and this causes damage to the cartilage, bone deformities, pain and progression of the disease. Simultaneously, there is also activation of the B cell because of the excessive T cell activation, and this results in the formation of autoantibodies, further exaggerating the processes. So the therapeutic objective in rheumatoid arthritis is to reduce the symptoms of rheumatoid arthritis such as pain, swelling and tenderness in the joints, and also to decrease the progression of the disease, decrease the disease activity, the erosion of the bone, cartilage damage, and improve the quality of life of the patient. To reduce symptoms, non-steroidal anti-inflammatory drugs or glucocorticoids can be used, and to reduce the progression of the disease-modifying anti-rheumatic drugs are used. So these drugs modify the progression of the disease and improve the quality of life of the patient. Coming to the classification of drugs that are used in rheumatoid arthritis, these drugs can be categorized as non-biological and biologicals. In non-biologicals, we have immunosuppressants which suppress the immune response, and these drugs include methotrexate, which is the drug of choice for the treatment of this disease, and other drugs are azathioprine and cyclosporine. These are also immunosuppressants that suppress the immune response. Other immunomodulators are sulfasalazine, hydroxychloroquine, leflunomide, tofacitinib. Amongst the biological agents, we have the tumor necrosis factor alpha inhibitors. Remember that tumor necrosis factor or TNF alpha plays a key role in inflammatory processes. Therefore, TNF inhibitors are used for the management of this disease, and the drugs are infliximab, etanercept, adalimumab. Others are tocilizumab, abatacept and rituximab. So now we will be dealing with each of these drugs in details. Methotrexate is the drug of choice for the treatment of rheumatoid arthritis. As we know that abnormal T cell activation leads to chronic inflammation and production of autoantibodies such as rheumatoid factor. So low doses of methotrexate is known to inhibit an enzyme. And what is this enzyme? It is AICAR transformylase enzyme. And because of the inhibition of this enzyme, there is accumulation of adenosine. So adenosine has anti-inflammatory properties. So because of the accumulation of adenosine, because of the inhibition of the enzyme, there is accumulation of adenosine which is anti-inflammatory in nature, and it reduces inflammation, it suppresses inflammation and controls the symptoms of rheumatoid arthritis. Also, high doses of methotrexate is known to inhibit an enzyme which is known as dihydrofolate reductase enzyme. So dihydrofolate reductase enzyme is the enzyme that is inhibited by high doses of methotrexate, and this is responsible for the formation of folic acid, which is an important component for DNA synthesis, RNA synthesis and multiplication and proliferation of T cell. So by inhibiting the enzyme, the folic acid synthesis is inhibited and the T cell proliferation and the multiplication is inhibited. So in this way, it suppresses the T cell multiplication in presence of high doses of methotrexate. Also, to be kept in mind that because of the suppression of T cell activation, because of the suppression of T cell activation, B cell activation is also suppressed, and this also reduces the formation of autoantibodies. So autoantibody production is also inhibited, the rheumatoid factor production is reduced, and this also prevents damage and controls the autoimmune disease. However, methotrexate is known to have certain toxicities. Hepatotoxicity is one of the important adverse effects of methotrexate. Now the next drug is azathioprine, which is a prodrug, and it gets converted to 6-mercaptopurine, which is an active metabolite. Now 6-mercaptopurine forms 6-thio-GTP, which forms a counterfeit product and falsely gets incorporated in the DNA of the lymphocyte, and this inhibits the DNA synthesis, the RNA synthesis, and the lymphocyte becomes non-functional. So this helps in the suppression of the lymphocyte and controls the autoimmune process. However, the use has declined because of high toxicity. It has a high toxic profile. It can cause bone marrow suppression, anemia, leukopenia, increase the risk of infections, hepatotoxicity, GI upset. Now the next drug is cyclosporin. As we know that interleukin-2 is responsible for the proliferation and stimulation of the lymphocytes, multiplication of the lymphocytes. So cyclosporin is known to inhibit an enzyme, and the enzyme is calcineurin enzyme. So calcineurin enzyme is inhibited. Now this enzyme is responsible for the formation of a nuclear factor that causes transcription and formation of interleukin-2. So the nuclear factor activated T cell is reduced, so there is inhibition of the synthesis of nuclear factor, and this inhibits the transcription of interleukin-2, which is responsible for T cell proliferation and multiplication. So cyclosporin, by inhibiting calcineurin enzyme, inhibits the transcription of interleukin-2, which is responsible for the multiplication and proliferation of T lymphocytes, and in this way it inhibits the immune response, decreases the activation of the T lymphocytes. However, a concern that is associated with cyclosporin is that it is nephrotoxic in addition to other adverse effects such as GI upset, hematologic manifestation, anemia, leukopenia, increased risk of infections, malignancies. So these are some of the drawbacks of cyclosporin. Now coming to the other immunomodulators, sulfasalazine, a derivative of sulfonamide, splits in the colon to form sulfapyridine and 5-aminosalicylic acid. Now do remember that 5-aminosalicylic acid is an active component in the management of ulcerative colitis and Crohn's disease. However, in rheumatoid arthritis, the active component is sulfapyridine. So sulfapyridine, an active component of sulfasalazine, is used in the management of rheumatoid arthritis, is used in mild cases of rheumatoid arthritis, or it is combined with methotrexate in the treatment of this disease. A limitation of this drug is bone marrow suppression. It can cause anemia, leukopenia. So blood count monitoring is essential when sulfasalazine is used. So the next drug is hydroxychloroquine or chloroquine. It induces remission in 25 to 50% of the patients of rheumatoid arthritis. However, a drawback is that it takes 3 to 6 weeks to achieve full therapeutic effect. So it has a slow onset of action, just like other disease-modifying antirheumatic drugs. And how does it act? The free radical scavenging property helps it to reduce the oxidative stress, to reduce inflammation. Advantage is that it has low toxicity. Again, the drawback is that there is low efficacy. So it is a low efficacious drug used in milder cases of rheumatoid arthritis, or can be combined with methotrexate for the treatment of this disease. Now moving on to the next drug, that is leflunomide. This is known to inhibit an enzyme known as dihydroorate dehydrogenase enzyme. So this enzyme is responsible for the conversion of dihydroorate to orate, and orate is responsible for the formation of UMP, which is a precursor for the synthesis of DNA and RNA. So by inhibiting dihydroorate dehydrogenase enzyme, it decreases the synthesis of a precursor which is essential for the DNA and RNA synthesis of lymphocytes, and thereby it inhibits the T cell multiplication and blocks the T cell replication and controls the immune response, controls inflammation, decreases the bone damage, decreases the erosion to the bone. However, the toxicities associated with leflunomide are hepatotoxicity, GI upset, hypertension and teratogenicity. So these are some of the side effects of leflunomide. The next drug is tofacitinib. This is a new drug approved by FDA for the management of severe cases of rheumatoid arthritis. It can be used as monotherapy given alone, or it can be combined with methotrexate. So in refractory cases of rheumatoid arthritis, if the patient is not responding to other drugs, tofacitinib can be used, and the advantage is that it can be given orally. As we can see here, the oral tablets of tofacitinib is available, which can treat severe cases of rheumatoid arthritis which does not respond to methotrexate and other drugs. But to be kept in mind that tofacitinib is not combined with biologic DMARDs. So not combined with biological disease-modifying anti-rheumatic drugs. Now, how does it act? It inhibits JAK-STAT signaling. Now, JAK-STAT is a cytokine receptor. It's a cytokine receptor, and as we know that cytokines play a very important role in inflammation. So, cytokines, by acting through the JAK-STAT protein, mediate inflammation. So, tofacitinib blocks the JAK-STAT receptor, decreasing the inflammatory pathway, inhibiting the inflammatory pathway and controlling chronic inflammation and the production of autoantibodies. So it is used in severe cases of rheumatoid arthritis. Notable adverse effects of tofacitinib is that it increases the risk of infections, that is respiratory tract infections, tuberculosis. It increases the risk of hypertension, and also anemia can occur. So these are some of the adverse effects that are associated with tofacitinib. Till now we have completed the non-biological antirheumatic drugs, which includes immunosuppressants, methotrexate, which is the drug of choice, azathioprine, cyclosporine. The other immunomodulators are sulfasalazine, hydroxychloroquine, leflunomide and tofacitinib. So these are the non-biological agents. Next we move on to discuss biological agents, that is tumor necrosis factor alpha inhibitors. As we know that tumor necrosis factor alpha plays a key role in the inflammatory cascade. It increases chronic inflammation, bone erosion, joint damage. So there are drugs that are developed to inhibit or block the binding of tumor necrosis factor to its receptor and controls the inflammatory processes, reduces oxidative stress, reduces damage. So which are the drugs that block tumor necrosis factor alpha? These are etanercept, infliximab and adalimumab. So adalimumab, infliximab, so these are monoclonal antibodies, and etanercept. So these are the three drugs that are tumor necrosis factor alpha inhibitors. These are very useful in blocking the tumor necrosis factor alpha activity and controlling the inflammation in the disease process. However, the limitations are it increases the risk of infections, it increases the risk of neoplasia. So these are some of the limitations of these drugs. What about the other biological agents? Tocilizumab. Now, tocilizumab is a monoclonal antibody which blocks the interleukin 6 receptor. It prevents the binding of interleukin 6 to the receptor. As you can see here, the interleukin 6 receptor, which is expressed in the cell membrane, and tocilizumab acts by blocking the interleukin 6 receptor, preventing the binding of interleukin 6, so preventing the action of interleukin 6. So interleukin 6 is a cytokine, it is responsible for chronic inflammation, joint damage, destruction. So blocking the interleukin 6 action helps in the management of the autoimmune process, helps to control the disease activity. So tocilizumab, a monoclonal antibody which is injected subcutaneously, and it can cause injection site reactions and also increases the risk of infections and neoplasia. Now the next drug is abatacept. Now we have learned that abnormal T cell activation is caused by the interaction between an antigen presenting cell and the T cell. As we can see here, the antigen presenting cell and the T cell interacting with each other, and there are two signals that are responsible for the activation of the T cells. One of the signals is the interaction between CD80 and 86 and CD28. So abatacept is a fusion protein that blocks the signal between CD80-86 and CD28. So the signal between CD28 of the T cell and the CD80 and 86 of the macrophage or the antigen presenting cell is blocked, and this further blocks the inflammatory process, the autoimmune response, the T cell activation is blocked, and this helps to control the immune response. It can be used in combination with methotrexate or TNF alpha inhibitors. So rituximab B cell depletion reduces the production of autoantibodies used in the treatment of severe rheumatoid arthritis. Now most of these monoclonal antibodies increase the risk of infection and causes injection site reactions. So with this we complete the drugs that are used in the management of rheumatoid arthritis, the mechanism of action, side effects, the limitations. So thank you so much for watching. If you like this video, please share and subscribe to this channel.